going to see the testing imaging testing that we do for lung diseases. We have non-invasive and invasive. The non-invasive include chest X-ray, CT scan, and PET, positron emission positive emission tomography. So the chest X-ray is the most common study that we ask. Sometimes it's the primary study that we ask. Sometimes we can see lesions in the chest X-ray before the patient has the symptoms, but we will not use chest X-ray to confirm the diagnosis of a pleural disease, interstitial disease, or the solitary nodule. But yeah, we can do chest X-ray, for example, for confirming the diagnosis of suspected pneumothorax, for example. The CT scan can be low dose, for example, angiography, in order to detect a pulmonary embolism, or non-contrast, for example, to detect the interstitial lung disease that looks like honeycomb lesion. A CT scan is done to assess the interstitium of the lung, mediastinum, and pleura, and is less sensitive to the movement of the patient than the chest X-ray. And we can see at real time, visualizing the imaging, the high resolution CT scan has slices, smaller slices, and we have so high resolution, and that is a CT scan without contrast. The PET or positive emission tomography is used for metabolically active lesions, for example, lung cancer. If the patient has a lung cancer or a malignant nodule, this malignant nodule is metabolically very active because the proliferation of the cell, etc., and needs glucose, etc. So it's metabolically highly active, and so there will be increased uptake that we will see in the positive emission tomography. So usually we do this in conjunction to the CT scan in order to localize anatomically the increased uptake that we're seeing in the positive emission tomography. This is an excellent test to detect early lesions, and sometimes if the lesion is very small, let's say a metabolically active nodule, yes, because it is small, sometimes we cannot see it in the PET scan, so it's not very recommended in small lesions. The other thing is that it's excellent in distinguish benign lesions, for example, scar tissue, versus malignant infections or inflammatory lesions. But between these three cannot be distinguished, or the PET cannot distinguish between these three. Now, the invasive procedures are lung biopsy, bronchoscopy, and video-assisted transthoracic surgery. So the lung biopsy can be done through CT or guided by CT scan guided, through bronchoscopy, or through surgery. The surgery can be open or can be through video-assisted transthoracic surgery. The open lung biopsy has more complications. The patient also needs general anesthesia and requires to be in the hospital, and should be done only after minimally invasive testings have failed to yield a diagnosis. The video-assisted transthoracic surgery is kind of similar to a laparoscopy. The indications are similar to lung biopsy, but also pleurodesis, pulmonary decortication, or lung or pleural biopsy. Now, the bronchoscopy, and in the CT-guided lung biopsy, we should be careful in patients with emphysema due to risk of pneumothorax. Now, the bronchoscopy can be rigid or flexible. Rigid bronchoscopy is used in management of advanced airways, or aspiration of foreign body. The lesions that can be accidentally done in rigid bronchoscopy is lip, teeth, or tongue damage, and also pneumothorax. Rarely, but also. A flexible bronchoscopy is used for bronchoalveolar lavage, bronchial brushing, endotracheal biopsy, transbronchial biopsy, final needle aspiration, and endoscopic bronchial ultrasound. The bronchoscopy is putting a endoscopic tube through the mouth, nose, or tracheostomy, and is done to assess the disease of the patient. Sometimes malignancy, sometimes infectious diseases, non-infectious diseases, and could be taking a biopsy or visualizing better. In biopsies, for example, the transbronchial biopsy, these indications are pulmonary nodules, infectious diseases in immunocompromised patients, or acute allograft rejection in the lung transplanted patient. And this biopsy, it has less risk in morbidity and mortality than the open lung biopsy. The bronchial brushing is to assess malignancy and infectious, usually. Bronchoalveolar lavage, after doing an infusion of saline through the tube, we collect the bronchoalveolar lavage, and indications include non-resolving pneumonia, diffuse infiltrations in immunocompromised patients, and diffuse non-infection diseases of the lung, and suspected alveolar hemorrhage. The final needle aspiration is to assess metastases in mediastinal lymph nodes, and the endoscopic bronchial ultrasound is done to assess the wall of the airways and the surrounding structures. The indications will be endotracheal lesions, mediastinal lymphadenopathy, and lung cancer in order to do the staging of the lesion. So, non-invasive techniques are chest X-ray, CT scan, and positive emission tomography. The invasive are lung biopsy, bronchoscopy, and video-assisted transthoracic surgery. The lung biopsy can be performed CT-guided or surgery through surgery, that would be video-assisted transthoracic surgery, or open, or through bronchoscopy, like in the transbronchial biopsy. The bronchoscopy could be rigid or flexible. Rigid would be used only for management of advanced airways or aspiration of foreign body. And the flexible is very helpful for bronchoalveolar lavage, bronchial brushing, transbronchial biopsy, endoscopic bronchial ultrasound, final needle aspiration, and endotracheal biopsy.